Welcome back everyone. Today's video is a deep dive into two critical classes of medications in nursing practice, antiplatelets and anticoagulants. We'll cover their mechanisms, pharmacokinetics, and clinical uses in a way that builds on our understanding of these drugs while keeping things clear and practical for patient care. So let's get started. Let's begin with antiplatelets. These drugs target the initial state of clot formation, specifically platelet activation and aggregation. Remember that platelets are the primary players when it comes to arterial clotting. In most conditions, such as atherosclerosis, platelets basically adhere to the damaged vessel walls and they begin to clump together, forming the basis of what we call a thrombus. Aspirin is actually a very classic example of what this thing antiplatelet is. It basically works by irreversibly inhibiting the cyclooxygenase. I'm finding it so hard to pronounce that. The cyclooxygenase 1 enzyme in platelets, which basically prevents the production of thromboxane A2. Thromboxane A2 is actually a potent vasoconstrictor, which is basically, constricts blood vessels and tightens them, and it also is an activator of platelet aggregation. By blocking this, aspirin reduces the platelets' ability to clump together and basically form clots. Next, we have clopidogrel, which is a P2Y12 receptor antagonist. Clopidogrel prevents adenosine diphosphate from binding to its receptor on the platelet surface, which again blocks the activation of the glycoprotein 2B and 3A complex, a key factor in platelet aggregation. This makes clopidogrel an important drug in preventing clot formation, particularly after stent placement or in managing acute coronary syndromes as well. Alright, now let's shift to anticoagulants. These are drugs that target the coagulation cascade, which is the body's process for forming a stable clot by basically converting fibrinogen into fibrin. Anticoagulants are very useful in preventing venous clots, which means clots that are being formed in the part of the body when the deoxygenated blood is returning to the heart. And in this place, the clotting process is usually slower and relies heavily on the coagulation cascade itself. One prominent example is heparin. Heparin works by binding to antithrombin 3, which inactivates both thrombin and factor XA. Thrombin is an enzyme that converts fibrinogen into fibrin, while factor XA helps to activate thrombin. Now, by inhibiting both these factors, heparin stops the formation of fibrin and effectively halts the growth of the clot itself. On the other hand, warfarin works by inhibiting vitamin K epoxide reductase enzyme in the liver. I know it sounds complicated, but this enzyme is essential for recycling vitamin K, which is again needed to activate factors 2, 7, 9, and 10. All key players in the coagulation cascade, of course, but by blocking vitamin K activation, warfarin effectively slows down the formation of these clotting factors. Lastly, you have direct oral anticoagulants like Rivaroxaban and say Apixaban. These medications directly inhibit factor XA, preventing thrombin activation without needing antithrombin as an intermediary. These drugs basically offer more predictable pharmacokinetics than warfarin, making them easier to manage almost every patient out there. Now that we've covered how these drugs work, let's dive into the pharmacokinetics about how the body absorbs, distributes, metabolizes, and excretes these medications. This understanding is essential for not only proper dosing but also for patient safety as well. Starting with aspirin. Aspirin is rapidly absorbed in the stomach and the upper small intestine. It reaches its peak plasma levels at about 30 to 40 minutes, and it undergoes the first pass metabolism in the liver. And this is where it is converted into salicylate, that is its active form. Its reversible action on platelets means that even a single dose can inhibit platelet function for the entirety of the platelet's lifespan, which is roughly at about 7 to 10 days. Clopidogrel is a prodrug, meaning it must be activated in the liver by the CYP2C19 enzyme to become effective. Its bioavailability is around 50%, and the peak plasma levels are reached at about 2 hours. However, CYP2C19 activity among patients can affect how well clopidogrel works. This requires careful consideration in patient management overall. For heparin, its short half life, about 1 to 2 hours, necessitates continuous IV infusion or frequent subcutaneous injections. It is primarily metabolized in the liver, with the elimination that happens through the kidneys. Close monitoring of the activated partial thromboplastin time is required to ensure that therapeutic levels are maintained without causing any sort of bleeding for the patient. Warfarin, on the other hand, has a much longer half life, about 20 to 60 hours. But its slow onset of action means that it may take several days to see the full effect of it. It's highly protein bound and is metabolized via the CYP450 system, leading to many drug to drug interactions. Hence, this calls for regular monitoring, which is, of course, critical to ensure that the patient stays within the therapeutic range, as the fluctuations in, say, the diet or other medications can greatly affect its efficacy. Direct oral anticoagulants like Rivaroxaban and Apixaban, they offer more predictable pharmacokinetics because these drugs are well absorbed and they have high bioavailability, about 80 to 100%, and they are again eliminated through both the kidneys and the liver. They have shorter half lives, which is about 5 to 15 hours. This actually allows for easier dosing without the need for any regular monitoring, but renal function must be assessed before starting therapy on these medications for patients. Now, let's talk about the clinical applications and the key nursing considerations one must keep in mind before administering these medications. Antiplatelets are primarily used in conditions where arterial clots are the concern. Say you have conditions like myocardial infarction, stroke, or maybe a peripheral artery disease. In such situations, the primary goal is to stop platelet aggregation, which is what drives the clot formation in high flow areas like arteries. Anticoagulants, on the other hand, are used in conditions where venous clots are the concern. You have risks like deep vein thrombosis, pulmonary embolism, or arterial fibrillation. In these conditions, we are basically trying to target the coagulation cascade to stop the formation of fibrin, which is critical in the stability of venous clots. As nurses, our role is to basically monitor for risks like bleeding, assess patient compliance, and manage drug to drug interactions. With warfarin, monitoring is very essential to ensure that the patient remains within the therapeutic range, while heparin requires the activated partial thromboplastin time monitoring, again for the similar reasons. For patients who are on direct oral anticoagulants like Apixaban, it is critical to assess renal function before and during the treatment to prevent any kind of drug accumulation in the body. To sum it all up, antiplatelets work by stopping platelets from clumping together and are used to prevent arterial clots where the pressure is usually high, whereas anticoagulants slow down the coagulation cascade and are effective against venous clots. Now, both these classes of medications require close monitoring, whether it's for risks of bleeding or drug to drug interactions or to ensure that therapeutic levels are maintained. Thanks for tuning in. If you found this breakdown helpful, then be sure to like, subscribe, and share this video with your fellow nurses. Drop your questions in the comments, and I'll be happy to dive deeper into any topics you want to explore further. Until the next time, stay curious and keep learning. Thank you.